Altered Physiology, Mechanisms of Disease 2, a continuation of our lecture series on alterations in the endocrine system with a focus on diabetes. In this particular episode, we will start to focus on the acute and chronic complications of diabetes. Hypoglycemia and diabetic ketoacidosis may present acutely in individuals with diabetes. If you look at the flow diagram on the right of your screen, what you can see is that when there is a relative insulin insufficiency, that it can have a number of clinical manifestations. Obviously, the extent to which you are deficient in releasing insulin will impact the types of symptoms you experience. Mild to moderate insulin insufficiency can be associated with high blood sugars and contribute to solute diuresis, or that production of urine, further contributing to excessive urination, which we call polyuria. This in itself may lead to dehydration, which also stimulates thirst, which we consider to be polydipsia. This can have other consequences, such as hyperosmolarity. Now, if we look at more profound or significant insulin insufficiency, whereby the pancreas is not able to release insulin, for example, this can have a significant impact on the breakdown of fat, known as lipolysis. This contributes to the formation of two types of acids, which present as ketones in your urine, as well as diabetic ketoacidosis. This can also manifest with Kussmaul respiration, which is rapid, labored breathing. Now let's have a look at some of the chronic complications of diabetes, including microvascular disease, macrovascular disease, and infection. We'll focus on microvascular disease first in the upcoming lecture slides, but notably this includes diabetic retinopathies, diabetic nephropathies, and diabetic neuropathies. The more classic chronic complications of diabetes that we think of are those of macrovascular disease, including cardiovascular disease, stroke, and peripheral vascular disease. And what you can see on the right-hand side of your screen is a clustering of risk factors associated with type 2 diabetes, notably the characteristic insulin resistance, but also in the context of obesity, dyslipidemia, and high blood pressure, all contributing to early macrovascular disease. Let's take a look, though, first at microvascular disease. Microvascular complications, as we've mentioned, can affect multiple organ systems within the body. Let's take a look first at retinopathies. Diabetes represents one of the most common causes of blindness in the United States. It has a very high correlation with the severity and duration of diabetes. This is another reason why controlling A1C is so important. In fact, high blood sugars are the primary cause of retinopathies, but the underlying mechanisms are not well understood. It may be due to the death of microvascular contractile cells, known as pericytes, and the loss of intracellular contacts, which leads to microaneurysms and leakage. Growth factors have also been implicated in retinopathies. Vascular endothelial growth factor is one such example. Now the next slide classifies diabetic retinopathies. You can have pre-proliferative or proliferative diabetic retinopathies. The various manifestations are listed on the screen here. And you can see their characteristics in this diagram as well. Next, if we look at diabetic nephropathies in patients with type 2 diabetes, we are essentially talking about impaired renal function, whereby the nephrons are not functioning normally. Moderate to severe renal functional impairment, as measured by a decline in the estimated GRF or glomerular filtration rate of less than 60 milliliters per minute, occurs in approximately 20 to 30% of patients with type 2 diabetes. When you follow these individuals over a period of time, nearly 50% of patients will have end-stage renal disease, which is defined as an estimated GRF of less than 30 milliliters per minute. 31% of patients will develop what is called macroalbuminuria, which goes on to become end-stage renal disease as well. The downstream effects are widespread. Not only does it lead to kidney failure, and it is the leading cause of end-stage renal disease in our Western world, but it is also associated with much higher medical costs. Now let's have a look at some of the underlying mechanisms associated with capillary damage within our kidneys. When our bodies digest protein, this creates waste products. We have capillaries in the kidneys which contain pores that are able to filter those waste products as your blood flows through the blood vessels, and ultimately these waste products can be excreted via the urine. Notably, useful substances such as protein and red blood cells are normally too big to pass through the holes in the filter, and therefore they stay in the blood. However, diabetes can damage this process. Notably, hyperglycemia places stress on the kidneys that leads to damage of the capillaries. Initially, patients with diabetes will actually have hyperfiltration and an increase in the estimated GFR rate. However, over time, capillaries start to leak and protein is lost in the urine. This is typically after several years. Having small amounts of protein in the urine is called microalbuminuria. There are treatments that can prevent kidney disease from getting worse. However, if the disease does progress, having larger amounts of protein in the urine can result. This is called macroalbuminuria. The risk of progression to end-stage renal disease is increased among these patients. The kidneys will essentially lose their ability to filter, waste products will build up in the blood, and the kidneys will fail. This is end-stage renal disease, and patients require either a kidney transplant or dialysis. Next, we're moving on to neuropathies. Diabetic neuropathies can present in one of two ways and also can be divided in terms of their effects: sensory, motor, and autonomic. The pathogenesis is not well understood, but may be due to an ischemic infarction of peripheral nerves. I should highlight that mononeuropathies is when you have damage to a single nerve. This can be associated with clinical manifestations such as numbness, pain, or loss of movement. The damaged nerve essentially prevents the spread of typical nerve signals. This is in contrast to polyneuropathies, which is when multiple peripheral nerves are damaged. This is referred to also as peripheral neuropathies and affects those nerves, therefore, outside of the brain and spinal cord. And that concludes this lecture episode.